So good evening, everybody. Tonight we have another video live endoscopy coming from Nijmegen this time, but not only from Nijmegen, as you will see. It's about the management of benign and malignant esophageal strictures and also benign esophageal perforations and leaks. And you see the panel members here, myself, but also Alana Ebigbo from Germany, Manon Spaander from the Netherlands. She was the chairman of the guideline on this topic. Rehan Haidry from London, Eduardo Rodrigues from Portugal, and finally, but not least, Lorenzo Fuccioto from Italy. And we start, I think, immediately with the first slide, but before I do so, I think it's important to let you know that we expect this webinar to last a little bit longer than 1 hour. Most likely it will be 1 hour and 15 minutes. And of course, you also see at the bottom of your screen the Q&A button. If you have any questions, please ask those questions and we will try to answer them during the discussion. Thank you very much. And we start with the first case. So the first case is a 70-year-old man who presented with dysphagia that was first noticed 6 weeks ago. Endoscopy was performed and this showed a stenotic tumor in the distal esophagus that only could be passed with a small diameter endoscope. Biopsy was performed and this showed a moderately differentiated adenocarcinoma. A CT was performed and this CT showed liver metastasis and extensive nodal involvement. And based on that, during the medical discussion treatment meeting, it was advised to place an esophageal stent followed by chemotherapy. So this stent was placed, and that's what you see over here. This is the patient and the tumor. We're looking inside the esophagus, and we decided to place a fully covered stent in this patient, as you can see over here. And this stent was actually not placed over the guide wire or apart from the endoscope. It was placed through the lumen of the working channel of the endoscope, so through the scope, fully covered stent, one of the new devices that is currently available. So no guide wire was used, as you can see here. And then, of course, if the stent is placed in position, you have to make sure that the scope is above the upper end of the tumor. And you see at the 6 o'clock position in this video, you see the yellow marker that is showing the upper end of the stent. And as you can see this this yellow marker, of course, then you know for sure that the upper end of the stent is released above the tumor, and that's being done here. So very carefully, the stent is being released here and making sure that the yellow marker is above the tumor, because that's the upper end of the tumor. And here you see the upper end of the stent. And here you see that the stent is almost completely deployed. The last part is being deployed. You see already the fully cover of the stent appearing in the distal part. It's fully deployed now, almost. And of course, when a stent is deployed, then in the initial phase, there's no complete expansion. It's nitinol, and nitinol needs to have the body temperature before it fully deploys. And that is something that will happen in the next 4 to 6 hours. And when the stent is fully deployed, it will extend in the esophagus, and then the patient will be able to eat a normal diet. So this is what can be done. So you can place the stent over a guide wire, but in this case, we place the stent through the esophageal channel, or the endoscope channel into the esophagus. So how do we treat patients with malignant strictures in the esophagus? And that's, of course, an important question. And then I go back again to the guideline. One option is to choose for a stent. And the other option is to use radiotherapy, and that can be done interluminally or brachytherapy or external beam radiotherapy. Another option is nutritional support with a PEG catheter or tube feeding, and sometimes dilation is being used, and sometimes argon plasma coagulation. But really, stent placement and radiotherapy are the most frequently used modalities for treating strictures in the esophagus. How effective is stent placement? I think that's also important to mention here. This is a study that was published 2 years ago in Endoscopy, or even 4 years ago, I should say, in Endoscopy, a study from Rotterdam, almost 1,000 patients that were treated with stent placement over a period of almost 25 years. And here you see the selection of stents that were used over time to treat these patients. And what were the results of these stent placement procedures? Well, stent-related complications were seen in almost 50% of patients. And what was very remarkable that pain was the most common adverse event, and it was associated with earlier chemoradiotherapy that the patient had, and also with stent type. Looking at the other complication, recurrent dysphagia, 31%, and of recurrent dysphagia, migration was the most important cause of recurrent dysphagia, and it was also associated with earlier chemoradiation therapy, and also with fully covered metal stent placement. Here you see the alternative for stent placement, that's radiotherapy. This is brachytherapy, and you see that for brachytherapy, a device is introduced over guide wire into the esophagus, and you see the position of this device in the esophagus, and using this device, it's possible to apply radiation therapy to the esophagus. And this is a study that was published already quite a few years ago, but it's an important study because it was a randomized controlled trial comparing stent placement with brachytherapy, the CYREX study. You see on the x-axis the time since treatment, and on the y-axis you see the dysphagia score going from 0, which means normal eating pattern, but also 3 here, that means that the patient was only able to eat fluids. And as you then look at the first period, the first, let's say, 30 to 45 days, then you can see that the improvement in the dysphagia score was much more prominent in the stent group as compared to the brachytherapy group. However, looking at over time, you see that the brachy effect lasted for a much longer period, whereas stent placement lost its effect because of stent migration or because of hyperplastic tissue growth. And that suggests clearly that in the beginning, stent placement is more effective, and over time, brachytherapy effect is more effective in palliation of dysphagia in these patients. So, is it important to use only brachytherapy, or can you also use external radiotherapy? That was the topic of a study that was published 2 years ago. And for this study, patients in the brachytherapy group were taken from the CYREX study that I just showed you. And for the external radiation therapy, another cohort was taken, a prospective cohort, and these 2 cohorts were compared. And there was one striking difference between the 2 treatments, as you can see, and that was that in the brachytherapy group, 33% of patients had improvement of dysphagia within 1 month. However, in the external radiotherapy group, that was 55%. So there are many more patients that had already improvement in dysphagia group in the external radiotherapy group as compared to the brachytherapy group. And that suggests that brachytherapy group maybe no longer needs to be used. And it's also possible to use external radiotherapy for palliation of dysphagia. Then the next question is, of course, and that's an important question, should we use stent placement or should we use radiotherapy in these patients? And from studies that have been done before, we know that the treatment choice should be guided by predicted survival. And this predicted survival can be based on the age of the patient, can be based on tumor length, can be based on the presence of metastasis, and also on performance score of the patients. And we know from the results that we have now that a stent should be considered in patients with a predicted poor performance score, so predicted survival of less than 4 to 6 weeks, whereas in patients with a reasonable or good performance score, a predicted survival of more than 4 to 6 weeks, radiotherapy should be the first option for treatment. So this clearly shows that both stent placement and also radiation therapy have a place in the treatment, in the palliative treatment of patients with dysphagia due to a malignancy. Having said that, I would like to discuss a couple of topics with the panel, and I think one of the questions that is important. Is there indeed a role for radiotherapy in the palliation of malignant dysphagia? And Lorenzo, could you comment on this question?
Thank you, Peter. Hello, everybody. Yes, I think that radiotherapy is underused at the moment for the treatment of, for the palliation of malignant dysphagia. I also believe that we have some problem with the literature, since in the last decade, the modality of treatment, the way we perform radiotherapy has completely changed. Now we have new techniques, new methodologies such as VMAT, which allow us to be much more precise and give higher dose to the tumor and thus be more effective. So I think this is something that we should consider more cautiously in the future. Furthermore, I don't know if you have any experience. We have this astonishing data from China with the use of Stent preloaded with radioactive seeds. So we know now at the moment they are not available in Europe, but I don't know if what is your feeling on this, if this could be exactly the future that is going to happen to us. So the possibility to have a stent and also a continuous brachytherapy within the esophagus that could be also improve the survival of our patients. What is your opinion, Peter, and also the colleagues of the panel on this issue? Have you any experience on this kind of stent? Because we have already 6 randomized controlled trials, all performed in China with very good results. This could be the future.
No, that's I agree. I mean, that's a very interesting option to consider. But as you say, all the studies that have been performed are from China, so there are no data coming from outside China. So I'm not sure about it, but well, looking at the results, it looks like a very promising modality that can be considered for the palliation of patients with dysphagia. Yeah, true. Maybe we should go to the Q&A box, and maybe I have a question for Manon. Manon, when do you need to use fully covered stents and when partially covered stents?
Thank you, Peter. Thank you, everybody. And thank you for this interesting question. As Peter has shown from the retrospective study we performed in more than 1,000 patients, you saw that migration was mainly due to the fully covered stent. However, in a randomized controlled trial where we used the same stent with the same features, we randomized between a fully and a partial covered stent, there was actually no difference with regards to recurrent dysphagia or other complications, both major and minor. So actually, it is just your choice or the choice of the treated physician which stent you want to choose and which stent you feel comfortable with to develop or to place.
Yeah, that's what I think as well. I mean, it is definitely not a real difference between the 2 stent types in patients with malignant dysphagia. That's also my experience. And of course,
we thought there would be more ingrow in the partial covered stent, but you see also overgrow in the fully covered stent. So, and that is comparable.
Exactly, and of course, these fully covered stents have a higher risk of migration.
Manon, may I ask a question on that? Do you think that the extent of the malignant stricture should influence, in this case, the kind of stent you use? What do you think on that?
Lena, absolutely good point, because indeed, when it is a really long tumor tract, I think that the risk of ingrow is higher in the partial covered stent, and usually then I choose indeed for a fully covered stent. Yeah, that is a good comment. And you, what you're doing?
I totally agree. Thank you.
Lorenzo, you raised your hand.
Yes, very practical point. So since we have about 50% of migration with fully covered, do you routinely suggest to clip or try to fix the stent, or you just wait the migration, then the second attempts you will put something, you will fix it?
For malignant cases, we don't clip the stent or use something else to adhere the stent to the esophagus. We do this for benign cases, and that's something we will discuss later on during this webinar. Yeah. And maybe we should go to another question. Maybe Eduardo, you can answer this question. Is there a role for chemotherapy to relieve dysphagia in these patients? What do you think?
Yes, I think it certainly has a role, chemotherapy, because there are data from the literature that shows us that patients on chemotherapy, they will have the tumor burden will reduce, and they will have their dysphagia improved. So I think it should be considered, even in the palliative setting.
Yeah, and especially when the patient is, of course, fit enough to have chemotherapy. Yeah, that's also an important argument, I think. Yeah. Yeah,
we
please.
have two quick questions from the audience I'm seeing in the question answer. So, can you still perform brachytherapy in a patient with stent? Yes, absolutely. Yes, you can do it. And also about the pain with brachytherapy, radiotherapy, you can observe during brachytherapy or radiotherapy pain, but the most frequent complication is the fistula formation or the migration, in case you have the stent inside. So it's not the pain, the most frequent side effects of brachytherapy. Absolutely not.
If I can say something, that even though there are some data also showing that adding brachytherapy after stent will improve outcomes, there's a recent RCT, open label, published on Lancet Gastroenterology and Hepatology, and radiotherapy after stents, it did not improve patient outcomes. The only outcome that was improved was reducing the bleeding from the tumor. So I think.
So Eduardo, yes, this is a good point, a really good point, because if you go into detail in that study, if you take the protocol that was published in trial, you see that the radiotherapy that the authors used is something that should no longer be used. It's a very, very old-fashioned way of provide radiotherapy to the patients. So actually, you have a completely different way of treatment. This is very important, because if you know that when you have the stent inside, the mean dose that you go to you provide to the tissue surrounding the stent cannot be controlled with the old technology. If you perform the VMAT, for example, you have just a range of variation is about 3%. If you go with the older technology, this go up 20%. So by this way, you can't control exactly the dose that you are irradiating the tissue. This is very important. This is the reason why, despite it's published on Lancet, that study, I don't think that the external validity nowadays is high of that study. And we should carefully always consider the technique, how the radiotherapy is provided to the patient, because this is strongly influence the outcome of these patients. I think this is a very good point that you raised.
Yeah, I think we need to always see the good point, the strengths and the limitations of each study. I was only stating that this study didn't show better outcomes.
I suggest that we move on to the next question. And that is a question on stent migration. And that's a question for Rehan. Rehan, do you think that for these patients, is there a special trick to prevent stent migration that's different from patients with the benign stricture, or is it basically the same tricks that we use for stent migration in malignant patients?
I think there's many considerations. Peter, we know that stents that are placed across junctional lesions are more likely to migrate. And so there's a question in the chat forum about which stent and which length of stent for what type of cancer. So your decision making in terms of what stent you use, your opening clip that you showed, the through the scope clips are very nice. They're very easy to deploy. You don't need fluoroscopy, but because of the delivery device, the radial force is less. So the migration rate is higher. But I think it also comes down to patient prognosis. So if a patient is going to outlive their stent, then you need to have a serious consideration about how you're going to secure the stent, especially if it's fully covered. In my practice, all fully covered stents, especially across the junction, we secure in place, both benign and malignant. And I'm sure we'll talk about later that there's new devices that are clip-based or endoscopic suturing to mitigate against migration. And I do these in malignant dysphagia, Peter, because often these patients are comorbid. Their quality of life is already impaired, and you don't want them to have a second endoscopy for repositioning of a stent or for a second procedure.
No, that's a very good argument, I think, to consider in these patients, that you want to stick to one procedure and that's enough, because the lifespan of these patients is so short.
Exactly.
For the sake of time, I think we will try to answer to the other questions in the meantime that are still not answered, and then we move on to the next part or the next patient. And that is a 49-year-old woman who presented with complete dysphagia and could only be fed through a PEG catheter. And she had undergone radiotherapy for an unknown malignancy 2 years ago, after which dysphagia developed. And during follow-up, no evidence of metastasis were found. And previous attempts to dilate the stricture were unsuccessful. So it was decided to perform a combined anterograde, retrograde, esophageal dilation procedure, and that will be shown in the next video.
Hello, everyone. Of course, I'm very happy to be here with, I think, the best experts in the world who can do this very difficult case. As you have seen in the introduction, it's a very difficult case, and we're going to try something that has been tried a few times. It needs a lot of experience and courage. Luckily, I'm supported here. I have with me Professor Peter Siersema from Netherlands. I have Dr. Prerecorded, and with us Mohammed Nijmegen. So yes, our plan, I'll leave maybe Dr. Peter give us initially an idea about the plan, what we're going to do.
Yeah, so what we found out is that the stricture is very high in the esophagus, so that makes it at least very difficult to maneuver from the upper part.
Okay.
So we decided to start from the PEG catheter. Mm-hmm. The PEG catheter has been removed, and as you can see, we left the guide wire in place. And the first step is now to enlarge the diameter of the PEG opening to make sure that the scope can go into the stomach.
To I think a maximum of 12 millimeters.
Yeah, we start with 12 and then.
So. Yes, we go to 3 atmospheres.
And then we increase.
Okay. And endoscope?
Yeah, it's almost next to impossible, but
you're doing a good job.
With you?
There's still a waste, yeah.
it's just needed 2 people to get it in.
Yeah. So the first hurdle is to find the cardia in this inverted position. Yeah, this is our direction. Yeah. Can you have a look at the screen? Should have used the cap. So yeah, you can see now on the screen that we're moving upwards.
I think you can do without the cap.
Yeah, this is the first step.
Yeah, that's maybe.
There's always
an optimistic side. Yeah.
So, my predict.
Could you give us something to put the guide?
Yeah.
I do not have any inflation at the moment.
Pump لا. CO2 is.
Okay, can I see the fluoro? Oh, still a long distance,
Still too far, huh?
Yeah.
That's what I did.
While you're doing that, we can push the wire a tiny bit.
Yeah.
Yeah.
Screen.
As Peter pushes the catheter.
Please. Guide wire, please.
Yeah.
Guide wire.
Yeah.
No.
Just stay there. Stay there.
It's good.
Yeah.
Again.
Try. Go.
I think.
We're almost there. So if you can straighten your scope as much as possible.
If you pull back.
This is, yeah.
Well, I'm a little bit afraid of using dye.
Can we get the
Because then
bronchos?
you-
Yeah,
Because
yeah,
that
yeah,
looks
I
like
think-
catheter, yeah? There.
Can we get the camera here?
Yeah.
It's out.
Yeah.
Perfect.
There we are. Good.
Yeah.
Ah,
So
Guy by that.
fantastic.
Yeah. Oh, there,
that's
your
enough.
catheters come through as well, Peter, now.
I think that's. I think we should
Yeah.
hold.
Has anyone got a mobile camera that we can shine in the mouth? Oh, open. Okay. So we can.
So I think we remove this catheter
Catheter,
now.
don't
Yeah,
need-
there we are.
So yeah, the balloons go in. Screen.
Okay,
Yeah, I think
go
you're.
back a little bit.
دكتورة ممكن.
Yeah, keep going.
send
Yeah.
a-
Keep going. Yeah,
Well done.
keep going. Yeah, fantastic. Is this maximum?
No, not much.
No.
So we're
Okay.
still.
Well, she needs to know what she's doing.
Okay.
So how much are we now?
So now we're at the maximum. 6.
Okay.
You want it further down? Ah. Okay.
Just wait. This is the place
Is the
where we have
balloon
to be.
too far up?
Yeah. That should be far enough, of course.
Screen.
How?
حاسب ايدك يا محمد.
Feel it.
Yeah.
Okay.
Okay. So, which size of NG tube would you recommend?
The biggest.
The
you can
12
put
French or the bigger one?
I would try this one. I'm not sure whether it will pass, but let's see.
This is quite big, but
It's quite big. How big is it?
this is about 12.
This is 12 French, the one I have.
No, we can
This is 20.
pay attention as well. Okay.
You're going okay?
So far, so good. Can we?
Already inside. Yeah, see, the tube is curling.
The tube is curling.
Yeah.
So, Hani, I'd like to start again all over.
Screen. Yeah,
Yeah, please.
minute.
Just 1 minute.
Midway,
Yeah.
all the way. You can see it. Yeah, there you are.
Oh, it's come through?
Yeah, you're going inside the channel now.
Oh, you're inside the channel.
Yeah.
Oh, okay.
How far it is in the stomach now?
Oh, this is in the endoscope.
It's in the endoscope now.
Okay.
Why? In case what?
Strap it to the wall. Leave it out.
But it's.
There
But we-
won't
we
be.
But I still see guide wire. Is that true? Hani, I think we can be happy with this final result, huh?
Again, we can't stress enough how difficult it was. We're all standing here. It was really stressful for us, for the anesthetist. So don't try this at home unless you have Pradeep and Peter on your back.
Well, I
Yeah?
would say the whole team here around, so because
Yeah.
they were all very successful
course.
and instrumental to achieve this success.
Yeah.
Okay, thank you very much. So as you could see, this was a very stressful procedure and it took a couple of hours to achieve this. And in the end, after a couple of months, this lady was able to eat. And that was, of course, the purpose of the initial procedure. When we look at the benign esophageal strictures, there are different causes. There's the peptic stricture, of course, that's the oldest known, but also post-radiotherapy, anastomotic strictures as a consequence of surgery, caustic strictures that are seen all over the world, people that are ingesting caustic substances, post-EMR, post-ESD, something new, and of course, eosinophilic esophagitis. And the new kids on the block are anastomotic strictures, post-EMR, ESD strictures, and also eosinophilic esophagitis strictures. And the question is, of course, how should we treat these patients? Well, the first step is always dilation, and that can be done either with a bougie or a balloon. And you see the difference here in this slide. You see on the left, you see a bougie, on the right, you see a balloon. And you also can see that the forces that are exerted by a bougie or a balloon are really different. At the same time, we know from studies that let's say the effect of dilation with a bougie or a balloon is not different. So the final effect of dilation is not different between a bougie or a balloon. And then, of course, the question always comes up: how far should we try to dilate a patient with a stricture? And in the literature, we know that there's the rule of 3, and that says that no more than 3 increasing dilator sessions in one session should be used. So, for example, a 9, 10, and 11 millimeter in one dilating session. And in very tight or long strictures, only 1 and 2 dilators should be passed in each session. It is also said that the initial dilation should be limited to a diameter of 10 to 12 millimeters, and it's also depending, of course, whether the scope can pass through or not, because then you can go up a little bit further. And the final diameter to be achieved is between 16 and 18 millimeters. And the question is, of course, is this rule of 3 really, should that really be followed? And that was actually the topic of a study that was performed a couple of years ago already, in which we looked at the association between perforation and stricture etiology. And as you can see, there's actually only one etiology that causes quite an increased risk of perforation when dilating, and that is malignancy. So with malignancies, you should be really careful in dilating the malignant stricture. So the question therefore is, should the rule of 3 always be applied? Well, the answer is probably not, because in this study it was also not found, it was found that non-adherence to the rule of 3 was not associated with more overall complications and also not with more perforations. So larger dilation steps in one session seem safe. However, you have to be careful with malignant strictures. The second step in this treatment algorithm is incisional therapy or dilation and 4-quadrant steroid injections, and this can also be combined. And that's actually the topic of the next video, and the video that was shared to us by Enrique Rodrigues from Madrid. And you see the main topics of this technique here. So here you see an anastomotic stricture in the upper part of the esophagus, and you see an IT knife, and this IT knife is being used to incise the anastomotic area. And that is actually quite a safe procedure. And the main reason is there is so much fibrotic tissue in an anastomosis that as long as you stay at the level of the esophagus, then the risk of perforation is actually limited. So there's not a very high risk of perforation, and you really should continue until you see the muscle fibers when you are cutting this fibrotic tissue here. And that's being done over here. And this IT knife is very helpful in doing this. You can also use a pre-cut knife, of course, but we prefer to use a IT knife for this procedure. And here you see the result coming. You see that the anastomotic stricture is nicely opening up, and at the same time you see that also the first fibers are being seen here, and that means that it's the point of stopping further incising. And then as a next step, this can also be combined with dilation, and that's nowadays more and more done. So here you see the balloon that's being introduced, and then it is dilated up to 60 millimeters, and that is even further opening the anastomotic area, and this can then be followed by steroid injections in the area. And what we usually do is injecting in four quadrants, and we leave behind 4 aliquots of 20 cc triamcinolone So altogether 80 milligrams. And the idea is, of course, that if you do so, that the risk of recurrent fibrotic tissue growth is reduced by injecting this steroids. So if this is not successful, and usually we repeat that another time, and this is not successful the first time, then we go to stent placement. And stent placement is also an elegant way of prolonged dilation of the esophagus. Here you see a couple of stents that are available for this. On the left side, you see partially covered stents, and on the right side, you see fully covered stents. And what is pro and con when we're speaking about stents? Partially covered stents has reduced risk of migration, but an increased risk of tissue ingrowth in benign strictures. And fully covered stents have an increased risk of migration and a reduced risk of tissue ingrowth. And as already was mentioned by Rehan, when stents are placed across the GE junction, then there's an increased risk of reflux. And the stents that are nowadays available have a very low risk of perforation and hemorrhage. And for this indication, for a benign indication, it's preferable to use fully covered stents. So what are the results? So the efficacy of stent placement for benign strictures is 40 to 45%. And safety is okay. Some stent migration, of course, also tissue overgrowth. And that is something that needs to be treated when this occurs. Stent removal is always indicated. You cannot leave the stent in place indefinitely, because that will lead to another stricture. And when the patient develops a recurrent stricture after stent removal, then a repeat stent placement should be considered. How long should the stent stay in place? That's, I think, also an important one. Should it stay in place for 2 weeks, or maybe for 6 weeks, or 3 months, or even 12 months? Well, in our own practice, it depends on dilation history. If a patient has a short dilation history, we leave the stent in place for 4 to 8 weeks. And when the patient has a long dilation history, we leave it in place for 3 to 6 months. And a new device that is increasingly being used for short strictures, for strictures shorter than 50 millimeters, is the lumen opposing metal stent. Here you see an example that was published as one of the first cases. You see here a patient with an anastomotic stricture, a short stricture. A lumen opposing metal stent was placed, and this was the final result when the stent was removed. The risk of migration is decreased, however, is not zero. So even these type of stents can migrate when they are placed in a tight stricture. When this is all not effective, you can also learn the patient to self-bouginage. That's an effective treatment in patients with proximal strictures. And finally, surgery is also one of those modalities that can be used at the same time. In the far majority of patients, we can treat them with endoscopic type of procedure. And that brings us actually to the discussion. And the first question is, of course, are there also other new modalities available that can be used to treat a benign esophageal stricture? And I would like to ask Alana to show us an interesting device that can be used for technique, I should say, for benign esophageal strictures.
Thank you for inviting me here today. I'm going to present a case of a severe anastomotic stricture, which we treated with a third space endoscopy assisted method. My name is Alana Ebibo. A 67-year-old patient was referred to our clinic. In June 2021, the patient underwent esophagectomy after neoadjuvant radiochemotherapy for a squamous cell cancer of the esophagus. He had a complicated postoperative cause and developed a severe anastomotic stricture, which had been treated with recurrent balloon dilatations and metal stents. The stricture can be visualized here in the esophagogram. In the EGD, we saw a severe anastomotic stricture and the opening into the gastric side of the anastomosis was initially not visible. But on careful further inspection and examination, we saw the tiny opening into the gastric side of the anastomosis. A 2.5 millimeter injection needle can be passed through the opening. So the stricture was about 2 to 3 millimeters wide. We decided to perform a third space approach for stricturotomy. Initial submucosal injection was placed and a mucosotomy was performed about 1 cm above the stricture. The aim was to create a tunnel adjacent to the stricture and subsequently cut or dissect the fibromuscular bridge creating the stricture. Dissection of the tunnel was made extremely difficult by severe fibrosis. However, this was to be expected. When the tunnel was long and deep enough, the fibromuscular bridge was dissected with a triangle tip knife, starting from the luminal side and towards the tunnel. The fibromuscular bridge can be seen here. The advantage of creating a tunnel first adjacent to the stricture was to allow an exact understanding of how deep or how far the stricturotomy could be performed. The outside wall of the tunnel served as a safe dissection border towards the mediastinum. After complete dissection of the stricture, the endoscope could now be passed easily into the gastric side of the anastomosis. The depth of stricturotomy was also guided by surgical clips, which can be seen here. Care was taken not to go deeper than these clips so as not to expose the mediastinum. On the first day after the intervention, the esophagogram showed significant improvement with widening of the lumen. The EGD performed on the second day after the intervention is seen here. The anastomosis can now be passed easily and smoothly. There were no complications. The post-operative course was uneventful, and the patients could be started on soft foods. In summary, we present the first case of a peroral submucosal endoscopic approach for stricturotomy. POSIS combines third space endoscopy with direct endoscopic incision of the stricture. Thank you for your kind attention.
Well, a very interesting case, Alana. And this was your first case, or was it? Have you done some more cases already?
No, this was the first case, and of course we have experience with direct endoscopic radial incision or direct stricturotomy, but because of the complicated nature of this stricture, it was also angulated, and also the radial stricturotomy would not have been possible because at the opposite side you could already see the tissue of the gastric pull-up side. So the depth of the incision would have been very difficult to judge. So and because of the tunnel, which was placed exactly adjacent to the stricture, it was very easy to follow the line of the tunnel for stricture dissection.
Interesting, very interesting. So Manon, having seen this, is there still a place for stents in benign strictures?
As you already showed in your treatment algorithm, there is a place for stent placement, especially for the refractory stenosis. And then the preferred stent is the fully covered stent. But to be honest, most of the time, the dilation treatment is effective, and especially in those cases where we have a radiation-induced stenosis or an ischemic stenosis, it just takes some time and basement to dilate it. And I think with regard to your rule of 3, especially these complex strictures, it is important to take preferable small steps than one big step, and take your time and then increase the intervals.
Yeah, that makes sense. I think the way you say this. Yeah, I agree with that. The next question is, what do we do with patients with strictures and benign esophageal eosinophilic esophagitis? Eduardo, is this something that you see in your practice, eosinophilic esophagitis?
Yes, so I have a lot of patients with eosinophilic esophagitis. So if they are well controlled with medication, they usually don't have severe strictures. However, sometimes when we catch them in the beginning of the diseases, and we may consider dilation besides starting them on medication with topical corticosteroids. And we know from the literature that the risk of adverse events is not higher than in the other etiologies. Some patients may report more pain after dilation. However, the risk of perforation is not higher if the technique is done properly. So usually I dilate them with balloons instead of boogies, and I do it gradually, increasing the balloons in some sessions, and I try to optimize medication.
So is the rule of 3 important in the eosinophilic esophagitis, you think?
So I think that the rule of 3 for me, it might be more important in the first sessions. So in the next sessions, I will guide my dilations to the previous diameters I have achieved, and how the stricture how the results we are achieving with previous dilations. So I think that I will be more aggressive in the further dilations than in the first dilation. So I think that the rule of 3 is important for the first dilation to see how the stricture behaves.
Yeah, that may well be. I think another topic that also needs to be discussed, that is, and maybe something, Rehan, you can deal with, because we also sometimes have these post-radiation strictures in the proximal esophagus, and those patients are being referred to us by the ENT surgeons, and those strictures are terrible to treat. What is your policy there?
Yeah, Peter, I think this is they're a really poorly served population. Not just the proximal esophageal cancers, but a lot of the head and neck patients will often be confined to, feeding through their gastrostomy sites that were placed pre-radiotherapy. You showed a very good example of your rendezvous procedure in a similar patient where, gaining luminal recanalization can be very difficult. I think the first thing in these patients is to establish nutrition, because these are very, very stubborn strictures and they won't respond in the same way that the benign strictures do. And then again, it's just establishing which are simple and which are complex strictures. And this is where your imaging and your index endoscopy is very helpful. These patients, these strictures are very fibrotic and they can be very, very tough. So my approach in these is to be quite aggressive with initial bougie dilatation. So they will come in and bring them in probably every week to try and dilate them. We now have some very, very nice cervical stents, which are proximal release. So in some patients, these can be used just to temporize things for 4 to 6 weeks before you jump other dilators. But the other thing, Peter, that has been very effective in our centers is self-bougonnage in these patients.
Yeah.
So once you can start and you can get them up to a luminal, to a bougie of 12 to 15, you can then send them home with a 42 or a 45 French self-dilator, and it's tolerated very well, and the side effect profile is low, and the quality of life outcomes afterwards are incredibly pleasing to see.
So how do you learn patients to self-dilate? Is there a special team for that, or how do you manage that?
Yeah, I call my nurse. So we're very lucky. We have an exceptional team. We have a nurse who's done this for over 5 years, 6 years. And it depends on individual patients. It's not for everyone. It's a real labor of love, and so they need a lot of hand holding. They need a lot of reassurance. But once they get established, it can be a big difference in terms of changing their quality of life and their ability to eat and drink with family and friends.
Yeah, that's I agree with that. It can be quite cumbersome for the patient as well, to have the confidence to start dilation. Yeah. Maybe a final question, and maybe for the audience, we will try to answer all the questions maybe at a later stage, and come back to that, because we don't have time to deal with all the questions. But maybe one question that is important, and that's also been asked by someone, and maybe that's something for Lorenzo. These peptic strictures with hernial diaphragmatic with a hernia, how do you manage those strictures?
Excuse me, Peter, could you repeat, because my connection was not very well. I can't hear you very well.
Well, we still, of course, also have these peptic strictures with hernias. Is that another type of procedure, or is it also one of the dilations that we do for stricture management?
Yeah, absolutely. We try always to optimize the treatment, the medical treatment. Then we start with the algorithm. Always to keep in mind that we have to first dilate the stricture, try to be not too much aggressive at the beginning, at least when there is still the inflammation on site. So we have be sure that there is a mucosal healing. So we achieve a complete healing of the erosive esophagitis, undermine the strictures, and then we go with dilation progressively. So I think this is definitely easier to treat when we compare with post-radiation treatment, with post-radiation or post-esophageal esophagitis strictures.
Okay, well, for the sake of time, and maybe for the audience again, for the ones that joined us later, we will continue until 8:15. We have one topic to discuss, and those are the benign perforations and leaks. And the patient that is presented here is a 70-year-old man who presented with coughing and choking, and also with difficulty with breathing. He had undergone definitive chemoradiation for esophageal cancer 6 months ago, and endoscopy was performed, which showed a small esophageal stricture and also a fistula with no evidence of malignancy. And it was decided to place a stent to seal the fistula. So during follow-up, the patient was able to eat and everyone was happy. However, after 12 months, he came back with the same symptoms as originally. An X-ray was performed and actually showed no stent, so the stent had migrated, and that was well, definitely not noticed by the patient, but he noticed again symptoms. It was decided to place again a stent, a fully covered stent, and use a clip fixation device to anchor the proximal and the distal flared end of the stent to the wall of the esophagus. Here you see a patient. On the right, you see the trachea, so a large defect. And in this patient, you see the situation here, a large defect on top. First, then the guide wire was placed, and over this guide wire, a stent was placed, as you could see over here. And it was decided to anchor this stent to the wall of the esophagus with a stent fix device made by Ovesco. And that's being seen here. This is the distal part. It can be sometimes difficult to pass the stent, especially in the beginning. But in this case, that was successful. So a stent fix device was placed at the distal part, but also at the proximal part over here. And here you see the X-ray with the final result on top, and also at the bottom you see a stent fix device, and that also led to the situation that the stent was no longer migrating. So here you see the device. It's an 80mm device that can be mounted on the top of the endoscope, the stent fix OTSC system, and it can be used to reduce the risk of migration in patients with an increased risk of migration, and especially in patients, of course, with no stricture, there is an increased risk of migration of the stent. There's also another technique, and this other technique will be demonstrated by Rehan Haidry in the following slide. But I first will go into this the diagnosis. There should be a low threshold for CT and gastroscopy when there's a clinical suspicion of esophageal leak or perforation. There's often delay in the diagnosis, but we know from a study published a couple of years ago that early diagnosis within 24 hours is associated with much better prognosis as compared to more than 24 hours. Treatment is resuscitation and antibiotics, and what is very important in these patients, drainage if there is fluid outside the esophagus. So drainage is an essential part of benign esophageal leaks and perforation management, and that of course can be seen in patients that present at a later stage. Stents we have already discussed. We have also discussed the stent fix device, and we know now from data that we have that the clinical success rate is 75%. Complications do still occur with stent placement as well, and the mortality is also 10%, although these are all the data, and I think that nowadays this mortality rate is lower than the 10% that is being presented here. So stents have been discussed. The OTSC can be used for smaller leakages or perforations. And another option is suturing. And again, Rehan, maybe you can show us how you can use this suturing device for treatment.
Yeah, and I might allude to some of that. So this is a patient with a Boerhaave, a patient with alcoholic dependence who presented. And it's really important, Peter, as you said, is that there's no need to close a hole just because we can. So this is a patient who presented, 7 days later. You can see the defect here. And the first thing is important is to get into the mediastinal cavity. This patient has an intercostal drain in, so I'm comfortable going into the intercostal, into the mediastinal space. And it's to remove all of this debris. Some of this will be esophageal tissue, will be hematoma. It's almost like a necrosectomy. Is that unless you remove this stuff, it's not going to come out with conventional intercostal drains, even if they're in the sort of posterior aspect. In order for apposition, it's really important to irritate and agitate the normal mucosa. So this is a patient who's going to have an attempt at endoscopic suturing. So you can see I'm going quite wide here. And then I'm going to use the Apollo device here, and I'm going to start in the normal mucosa, start at the anal end of the defect. And the benefit of this device is it allows you to get transmural sutures. In the esophagus, it can be very difficult because you don't have the benefit of using the helix, which we use in the stomach for bariatric procedures. And so it's really important to have a plan here as to what your suture pattern is going to be, and you can see that I've actually mounted the device differently from what we would use for other applications. So the needle drive is coming from the 9 to the 3 o'clock position. And that allows me to use a zigzag pattern to try and oppose the tissue and place my first suture to try and get closure. What I do then is I basically put methylene blue in my irrigation pump, and then put the intercostal drains on negative suction, and we'll just basically marinate the esophagus for about 5 minutes. And if what comes out of the intercostal drains is still blue, that means I still have a leak. And so then I go back and, you can reinforce your first suture and then repeat that over and over again. Sometimes I find that an on-table esophagram is not, it's not dynamic enough. So if there is a small leak there, you can't see it. And so with this device, you can go in a very systematic manner. You can see I'm just reinforcing my first suture by taking slightly more generous margins from the defect. And the important thing here also is not to put too much tension on these sutures, because the tissue will come together from mucosal healing, from the APC and from the disruption. And invariably you will create a slight stenosis here, which is really, in the bigger scheme of things, not a big issue. And then you can see here on the final pass, the defect is closed, and on this pass of the methylene blue, there was almost no dye coming out of the intercostal drains. So I think that the take-home messages, Peter, from your slide on these defects is that not all holes need to be closed. It's really important to think here a little bit more laterally and think about the three-dimensional space. The mediastinum is a closed system. And actually stenting or closing a defect, if there's a collection, may not be the right thing to do. So it's optimizing the resuscitation, the antibiotics, working very closely with your surgeons, with your radiologists to understand where the defect is, where the collections are, and making sure that the mediastinal space is drained appropriately before we consider closure. So it's a very multidisciplinary approach, and these patients need to be managed in a high dependency intensive care setting, because what will kill them is not the defect, it's the mediastinitis and the physiological fallout from that afterwards.
I fully agree. I mean, this is a multidisciplinary team a patient, and so that's every day it's a different situation, and you need to adjust your treatment to the day, how the patient looks like, etc., etc. Yeah, and the suturing device can also be used to suture a stent to the wall of the esophagus. Huh?
Yeah, I think that's another important indication. Peter, you showed a very elegant video of the stent fix device. The stent fix device is very easy to use. We have had a couple of poor outcomes with pain, but also a fistula, because it sometimes can be quite variable in terms of the thickness of tissue that you get in your bite. And so this is another option which you can secure the stent in place. The suturing is something that I like to do for essentially iatrogenic strictures post circumferential ESD. If we put a stent in, then I'll suture them in, just because I don't like the tissue ingrowth that you get with the stent fix, because that can create some discrepancy when you're sampling a post-resection site.
Yeah, that's a good point. Maybe that's also an argument, maybe to consider suturing. Yeah. The issue here, of course, is that suturing the esophagus is not so easy because of the limited space that you have. Huh?
It can be very tricky, but the devices will improve. Apollo endosurgery will have already launched in the US through the scope device, which as soon as we have a CE mark will be available here. And instead of an over the scope platform, a through the scope device will allow us to be able to get increase the sort of umbrella of indications such as defect closure and perhaps even stent fixation to a more general user audience.
Well, thank you very much. We move on with the remaining slides. So we have had stents, we have OTSC, we have had OTSC, we have had suturing, and another interesting device is endoscopic vacuum therapy, and that's been shown on the next video. It's running here. So you see a patient with again a leak after surgery, an anastomotic leak. And as you can see here, it's not very difficult to go inside the mediastinal cavity, the same way as was seen before. Cleaning is an important part of it before treating it, and as much as possible, the necrotic debris needs to be removed, and that's being done here. And then When that has been done, then we can use a very interesting device, a sponge connected to negative pressure. Here you see an overtube being introduced into the esophagus, and this overtube is being used to introduce this sponge into the esophagus. It can be placed intraluminally or into the defect in the esophagus, depending on the size, of course. But also in the esophagus, these sponges work very well. You need to work hard, as you can see. It's quite well. You need some pushing, but at the same time, when it is released, you feel this, and then it's nicely positioned in most circumstances. The push is being removed, and you see then that the sponge is connected to a tube for negative pressure. Then the overtube is being removed, and then the tube is connected to a negative pressure pump that can be seen maybe on this slide, but at least the principle. So the sponge can be placed in the mediastinal cavity or in the lumen of the esophagus. Continuous suction, 100 centimeter water, and finally it should be replaced, as the company says, and is also been seen in daily clinical practice, every 3 to 5 days. In the beginning more frequent, and later on a little bit less frequent. And usually in 2 or 3 weeks, very large defects have almost completely closed, like here in a drawing. So you see a large defect here, and then you see over time that the size is decreasing, and then finally there's a closure of the leak in the esophagus. So, and when this is all not successful, there's always surgery. At the same time, I think we have now so many interesting devices to treat these leakages and perforations that the surgeon is no longer very prominent, at least in treatment. Of course, in the multidisciplinary team, but not in treatment anymore. And surgery is not as frequent as it used to be. So, what could be a treatment algorithm that can be used? Well, what we do in our practice is we make a differentiation between small leaks or perforations and intermediate and large leaks and perforations. What is also important is this time frame. So less than 3 hours, less than 24 hours, more than 24 hours, less than 1 week, and more than 1 week, because that also determines the treatment that will be taken. For small lesions, it can be endoclips can be used, of course, as we usually do also. OTSC can be used for leaks smaller than 2 centimeter. Suturing, you have seen. Stent placement, you have also seen. Endoscopic vacuum therapy, you have seen. And finally, there's always surgery when this is all not effective in a patient. And again, this is less and less common these days with all these devices that are available. So that brings us actually to some discussion points. And one of the discussion points may be, Alana, for you, what is the preferred stent type? Is it a partially covered stent in your opinion, or is it a fully covered stent for treating benign esophageal perforations and leaks?
Yeah, I think we should use fully covered stents because that's the essence of we are trying to cover up the perforation completely. So I think here the rule is clearly for fully covered stents. Maybe we also need to mention at least the endoscopic vacuum stent in this situation. There is, I agree, limited data only on the endoscopic vacuum stents, but at least it may be an interesting option, work in progress also, but it may allow or enable the patient to at least take fluids and at the same time combine the advantages and the effects of endoscopic vacuum treatment.
It would have been one of the questions I would have for you, this endoscopic vacuum stent. But again, I mean, we need more results there, but it's an interesting device to use in these patients as well. So maybe for Lorenzo, what's the experience with OTSC for leaks and perforation in the esophagus? Can you comment on that?
Yeah, we have few experience with this device because it's you have to be lucky that the perforation, the leaks is very small, and to be sure that you can grasp the margin and put all inside the OTSCHC. You have to be very careful when you release this device, because otherwise you can also create a stenosis. But yes, it's very fine. You have to be always sure that you have, as you have already said, that there is no abscess, no contamination of outside the leak, so before closing. But this is because this is very useful device. So yes, you have to be sure that all the tissue is inside your OTCSC. So for very small, under 20-15 millimeters, to be sure to have all the tissue inside the OTCSC.
Yeah, I agree with that. Eduardo, what are the options when we make a perforation? Is one of the questions from the audience. What are the treatment options in a patient with achalasia that has been dilated with pneumatic dilation and develops a perforation?
So we can, if there's a linear laceration, we can try to place through the scope clips in a zipper fashion. If we, like when we're closing a laceration from a poem, starting on the distal defect. If it's a small defect, we can consider over the scope clips. We can place large stents, large diameter stents. However, often the esophagus is quite dilated, so it's difficult to have a watertight sealing of the stent to the mucosa, and we can consider vacuum therapy. So I think that for acute perforations, we'll have better outcomes, and we have more availability to treat, more options to treat these patients. While for leaks, which are more chronic, we need to adapt the strategy to the point where we are treating the patient. If the patient had a previous surgery, which kind of surgery it was, if it was bariatric, if it was oncologic. And nowadays we are moving more to concepts of keeping the defects open and trying to close the defects by second intention with vacuum therapy, endoscopic internal drainage. Even endoscopic internal drainage is being adapted in oncologic leaks with good outcomes. So I think that all strategies can be considered. We have to adapt to the defect, the size, the diameter of the esophagus, the chronicity of the defect, all of that.
Well, one of the advantages of an achalasia leak or perforation is, of course, that you recognize them immediately. So there's no contamination. That at least improves the prognosis of the patient, in my experience.
Yeah, it's true.
Okay, let's move on to the next question. Well, that's something that was already discussed, the EndoVac stent. We need more data there. Is there anyone else who has experience with the EndoVac stent? Not yet. Well, that maybe for the webinar in 1 or 2 years' time about the same topic then. And then, of course, this endoscopic vacuum therapy. Is anyone of you that has experience with this sponge therapy in patients with leakages and perforations?
I have.
So what is your experience? Do you place the sponge intraluminally or intracavitary?
So in my experience, and also from the literature, we know that the result will be better if we place the sponge in the cavity. So we will be more likely to have success if it's done like this, because often when it's intraluminal, we are not able to aspirate secretions and promote the tissue granulation as well as we will do it on the intracavitary. There are some issues with placing it intracavitary. Sometimes the access to the cavity is quite difficult, and we can use overtubes like it was showed. We can use other techniques like the backpack technique, where we grab a small nylon loop attached to the sponge with a forceps. However, sometimes it's difficult. We can also use homemade sponges, and we can adapt the size of the sponge to the defect. And we can also consider dilation of the defect in order to make it easier to place the sponge in the cavity. So usually when I place the sponge in the cavity, I try to change it more often, and I will do it like 3 to 5 days. However, if I place it in the lumen, I will leave it longer time. I can leave it up to 1 week. And ideally, these patients should have a nasojejunal tube to allow them to be feeding, to have alimentation, because we know that we will improve outcomes if patients are more nourished.
I think there are just two quick practical points, Peter, if I may, to the endoscopic vacuum therapy is, number one, it's not quite clear how much negative pressure we need. Eduardo, we use something between 100 and 125 mmHg. But I know that there are some centers that even go higher than that, or some centers go lower, remain between 50 and 80. So I don't think there's sufficient data on that. And the second point, which is very important, is, and which we have experienced also negatively, is if there is no negative pressure for one reason or the other, if the negative pressure pump doesn't work, then you have an extremely detrimental situation, because you have a complete clogging with the sponge, and there is no negative pressure on the sponge. So this has to be checked continuously by the nurses in attending to the patients.
Exactly, and there's a third point, and that's our experience. That is that this sponge, especially when it is placed in the cavity, that sometimes it adheres to the wall, and then it's very, very difficult to remove it.
So it's important to add a lot of fluid and wash the sponge before pulling it out.
Exactly.
That's also a very important practice.
And also with the scope, we can pass beside the sponge and try to remove it from the cavity before pushing it out.
Yeah, that's another trick. But I also agree that a lot of fluids are also important there.
Yeah.
And that also will weaken the sponge a little bit and make it easier to remove. So we have come to an end of this webinar. Is there anything that we have not discussed but need to be discussed? I'm looking at all of you. Lorenzo, Eduardo, Rehan, Manon, have we forgot? Of course, also Alana, have we forgot something? That
but it was just an interesting question. What I was also thinking is that in those cases, the benign cases, when you want to perform a stent removal, how to do it when you have an oesophageal stent fixation?
Yeah, that's a very good question. Has anyone experienced with removing a stent that is fixed with a stent fix device?
So usually in my practice, when I go to remove the stent fix is already not very well fixed to the mucosa, and it's easy to remove the stent without any special technique. However, we can consider a special dedicated device, which is the OTSC remove system, and it has good results. However, I have never needed to use it in this situation. I have used it in other situations when I use, but not to remove a stent.
No, I agree with that as well. I mean, it's usually quite easy to remove the stent together with the stent fix device just by pulling on it, because it's not that well fixed anymore. How do you do this with suturing, Rehan?
With sutures, it's very easy. We could use either endoscopic scissors or some APC to cut the sutures. Just to add to the point, if you leave the OTC clip too long, sometimes you can get a lot of tissue overgrowth and pain we've had on removal. So I think it is a really important thing to make sure that you're diligent with when you take these stents out, because if you leave them too long, then even the DC cutter sometimes can be very difficult to remove the clip.
Well, thank you very much. We will try to answer to the questions that have not been discussed at a later stage and come back to you. Thank you very much for joining. We have a couple of final slides. Of course, it's important to remind you to ESGE Days 2023. Early bird registration deadline by the end of February. It's cheaper then. And of course, we like to see you all in Dublin. It is really the endoscopy celebration of the year. And I hope to see you all there in Dublin, of course. Another important thing is we always celebrate the Innovation of the Year, Innovation of the Year award. If you have something that you would like to submit, please do so before February 1. And of course, it may well be that your innovation will be selected for the Innovation of the Year award. Don't forget, ESGE is the face of endoscopy in Europe, but not only Europe, worldwide. There's a lot you can get from ESGE, learning materials, these webinars, and of course also free subscription to Endoscopy Journal. And then finally, in 2 weeks' time, there's another webinar. It's about green endoscopy, an important topic, maybe the important topic of the future. And it will be discussed by a panel of great experts in the field. And I really look forward to this webinar in 2 weeks' time. We hope to see you then again. Thank you very much for joining. I'd like to thank the panel for joining tonight. Thank you for a very fruitful and interesting discussion. And I wish you a very pleasant evening. Thank you very much.
Thank you. Thank you very much. Bye-bye.
Thank you.
Bye.
Bye-bye.
Ciao.